It's 2 minutes after the hour. Why don't we go ahead and get started? Hello and welcome to this Black History Month lecture by Professor Molly Collins. We are delighted that you're going to be joining us for what we're sure is going to be an inspiring and thought-provoking talk. This talk is co-sponsored by the Harvard Medical School Center for Bioethics, the Harvard Medical School Office for Diversity, Inclusion, and Community Partnership, and the National Center for Bioethics in Research and Healthcare at Tuskegee University. I'm Wes Boyd. I'm a psychiatrist and director of education in the Center for Bioethics here at Harvard. Throughout Dr. Collins' presentation, I'm going to be monitoring the chat because this is webinar format. You'll be able to enter questions directly into the chat that I'll see, and then I will be offering those questions to Dr. Collins at the end of her prepared remarks. About Dr. Collins, Molly Collins is an assistant professor of African American and African diaspora studies at American University in Washington, D.C. Her research areas include Black motherhood studies, Black archival studies, 20th and 21st century literature and art, medical humanities, digital technology, and reproductive health and justice. She is a practicing doula and a trained perinatal and infant loss advocate with the Womb Room in Baltimore, Maryland. Professor Collins has been the recipient of numerous awards and fellowships, has published articles in many peer-reviewed journals, and has also published creative poems and short stories in multiple venues as well. Her forthcoming book will be this summer by Ohio State University Press and is entitled Scrap Theory: Reproductive Injustice in the Black Feminist Imagination. I'm also particularly delighted that Professor Collins is going to be a visiting scholar with us in the Center for Bioethics at Harvard Medical School this fall. Her talk this evening is The Carceral Hospital: Race, Birth, and Imagining a Different World of Health. Professor Collins, it's all yours, and thank you so much for being here.
Thank you, Dr. Boyd, and thank you everyone for joining this evening. I want to first start by, again, thanking Dr. Boyd, Ali Stitham, and also Roberto Servant for supporting me in giving this talk. And then, of course, a special welcome to the students at the Institute for Bioethics and also Tuskegee University if they are here tonight. And then just everyone else for sharing this hour with me. I want to first start off by naming a few content warnings for this talk. I will be talking about maternal death, the conditions of imprisonment, and the imprisonment of children. And I detail these things not necessarily to be graphic or gratuitous, but so that I can really impart the particular violence of healthcare that doesn't just impact the futures of adults, but also children as well. In this sense, we can see how the definition of carcerality, which is defined as of or relating to prison, becomes especially acute when we talk about pregnancy. And sorry about that, when we talk about labor, pregnancy, and birth. And so I will hopefully, Ali, we're having some tech difficulties, so just give me 1 second. Okay, so I will also discuss why the Black pregnant body, the laboring body, and the birthing body is attacked during and long after one's experience in the hospital. This is all woven together through very literal and figurative formations of debt that are instructed to us by Black feminists. So it may be clear from my biography that Dr. Boyd just read that I approach questions of Black maternal health, debt, and reproductive justice as a scholar of medical humanities. And that means that when we approach these topics from a place that values lived experience as it's testified in the spoken, written, and sometimes creative forms, new methods through which these truths about power and medicine can really fully emerge. My current approach utilizes a reproductive justice analysis to expose lies told about people who have medical debt as those who are non-contributive to society. Some of these lies often depict those with debt as irresponsible, as unworthy of care, or even poor planners. Reproductive justice allows us to think more expansively about debt, about indebtedness and what it means, not just in terms of a fiduciary obligation, but also an obligation that's stamped onto mother-child relations. For too many years, I believe that bioethicists have been asking questions of race, gender, and power that have led us to wrong answers about Black women, almost treating us as if we are solely responsible for our own poor health outcomes. Some people, like a recent Southern congressperson, I believe, or I believe a governor, actually said that maternal mortality rates wouldn't be so bad if you just didn't count Black women in their state, right? I believe that this sentiment or this rhetoric that's being deployed is also kind of similar to what a lot of bioethicists say, or excuse me, what they refuse to believe, which is, beliefs in which we have to really confront the histories that have excluded Black women from not just the category of a mother, but also the category of human as well. When studied, these histories refute the lie that Black mothers are responsible for the symptoms produced as a response to the social sickness called racialized violence. Black mothers have much to teach us about the truth of power. If we listen, we could shape a new field of bioethics rather than build upon the lies of which power attempts to convince us. A reproductive justice lens illuminates how medical debt and medical violence intervene on the autonomy of Black women's reproductive futurity. A reproductive justice lens allows us to see how reproductive injustice compounds to erase certain liberties while also producing a Black reproductive subject that will then owe the state, hospitals, and/or corporations for their and their children's lives if they're fortunate enough to continue their lives after pregnancy, birth, or postpartum. This cycle of owing then turns into both figurative and literal forms of debt that go on to incarcerate, and sometimes in the most literal sense, incarcerate Black mothers for simply surviving in a world inflicted by gendered and racialized violence. So in sum, reproductive justice really exposes lies disguised as social conditions that mark those with medical debt as irresponsible or as unworthy of care. It allows us to think more expansively about debt, not just about the fiduciary, but also really what it means for entire communities. Reproductive justice has never just encompassed the right to have children, right? I don't want us to, I don't want this talk or really any type of idea about reproductive justice to be grounded in the idea that this started in the 70s when white women decided that they wanted to go back to work and everyone was burning their bras, right? That's like a terrible fallacy of what reproductive justice is. It also extends to the right to have children, the right to not have children, and the right to raise children safely into adulthood. There are and were multiple large-scale movements that have incorporated women from all walks of life and have crossed class and racial boundaries. One in particular is the Atlanta washerwomen's strike that was actually in 1881, in which mainly Black but also Irish domestic workers amassed 3,000 different laborers to double their pay in order to constitute for very long hours away from their children and families. And then, of course, on the right-hand side of the screen, we have Ida B. Wells Barnett's anti-lynching campaigns, which she waged for the futurity of not just Black boys, but mainly everyone in the South at the time. And she waged her war through media campaigns and also through lecture circuits. And she did this mainly accompanied by her 4 children. And I think it's really important to also note, just on a personal note, that suffragette Susan B. Anthony, who's often heralded as kind of starting reproductive justice, right, within 1919, this fight for white women's vote. It was actually Susan B. Anthony who is cited as writing Wells Barnett letters and telling her that she needs to stop bringing her children on the lecture circuit, saying that she's distracted by her children, that she should have never become a mother because mothers really have a hard time getting things done. But I should also note that Black reproductive justice movements have also intersected with fights for broader civil rights, not just to show how, Black mothers have really been instrumental in things like the Montgomery bus boycotts. It would have never even been possible if Black mothers, who at the time were domestic laborers, they decided to forego the bus lines. It would never have been possible without Black women. We also have civil rights icon Fannie Lou Hamer here on the left. Those are not her children, but she's posing with family members. Fannie Lou Hamer was forcibly sterilized by her doctor in Mississippi called a Mississippi appendectomy, right? So I'm sure you can understand the name. One goes in with stomach pain, or one goes in thinking that they need to have their appendix removed, but Black women were always returning with not just no longer having an appendix, but also a uterus. And I could really go on and on about how these movements have been collapsed by the labor and the activism of Black women. But reproductive justice, right, this more radical analysis has long encompassed more than what's often taught. I just want us to really understand that. So rest be assured that the activism around Black maternal health is also more expansive than what just takes place in the hospital, okay? So for instance, this is especially true under the reproductive justice tenet of raising children safely into adulthood, which also was instructed to us by Ricky Solinger and Loretta Ross, right? And when we think about reproductive justice as the right to raise children safely into adulthood, we can then understand how institutions don't necessarily just encounter vulnerable Black children, but that the institutions that our children are in are actually, in fact, making the kids more vulnerable, if that makes sense. So we have schools, we have juvenile detention centers, foster care homes. All of these entities have been studied as extensions of prisons. This is because prisons, schools, and I contend also hospitals, are shaped by conceptions of race, gender, and class, which compound to subjugate children. Hundreds of years of poor treatment have been systemized and institutionalized to now what we call these social determinants of health. We should also be considering the sexist and racist determinants that have shaped the advent of the hospital, okay? If we're really going to take these things like the school to prison pipeline seriously, or these pipelines to prison, we also have to look at the hospital. For far too long, constructions of power have long decided who gets care, where they can get care, or the quality of that care. This produces edifices called hospitals that are contoured by tenets of isolationist, expert-centric care that fundamentally restricts bodily autonomy on many, many levels. So despite the title of this talk of the Carceral Hospital, I want to be clear, of course, that a hospital is not a prison, okay? So just as I'm sure that school abolitionists would argue that a school is not a prison or a foster home is in fact not a prison, we also have to look at the trajectories of the school to prison pipelines and these pipelines set out for us and how they disproportionately lead Black children to incarceration through their tactics of physical, emotional, and educational discipline within this space. Or as Dorothy Roberts asserts, that with the number of Black children being, quote, kidnapped into the child welfare system is disproportionately Black and Indigenous, I am led to believe that the history, systems, and culture that now make up the single edifice, right, has called the hospital, has also grown complicit with keeping these pipelines active and thriving, fueled by the myths of Black mothers as unfit mothers and deserving of poor treatment and debt. In sum, Black pregnancy and birth is a gateway for fully understanding how multiple forms of debt are appointed as a means to punish and discipline Black reproduction and those who have children in an attempt to raise children in a future of freedom in a world full of edifices, logics, and systems of unfreedom. The Carceral Hospital attempts to disrupt this potential freedom at the stage of conception and pregnancy and punishes those afterward with debt. There are many ways that we could discuss the carceral logics of a Black mother's hospital experience. In previous work that I published with Dr. Lynette Park of Emory University, we've considered the midsection monitor and the mandate of supine positioning under what Freud would call the disciplining of the body for the benefit of the medical provider. In this sense, we can scale shackling inside and outside the prison industrial complex to cut across ways these surveillance techniques are used to monitor the imagined racialized, violent, and uninhibited body. The restraining device paradoxically increases the need for surveillance as it simultaneously reinforces its own demand, its own wish to presume that there is the so-called violent female body to hold captive and restrain. In today's birthing room, there is an identifiable technology that disallows free movement, and that hinges on the replacement of caregiving, right, or monitoring from a midwife, nurse, or obstetrician. And it's replaced with this type of surveillance through the midsection fetal monitor. As many here understand and know, the midsection monitor collects the fetal heartbeat, right, which is then collated and reported to monitor at the nurse's station. The midsection monitor or shackle or restraint materially restricts birthing bodies, and its use can be understood as a response to the historical racial anxieties of Black birthing bodies. The midsection shackle limits the movement of the woman giving birth, but also as a consequence forces the body into a position in which their movement as a whole and their body, including the uterus, must be monitored. The surveillance, which is guised as choice, operates under the auspices of providing safety at the behest of providing hands-on birthing care. It also keeps the body in the bed and on the back, which has proven to prolong labor. In short, the midsection restraint is one of the many technologies of the contemporary birth scene that appears to give birthing people this choice to move around or this choice to be on the birthing ball, but it's actually intertwined with questions of access, racial capitalism, and disciplining the body for further surveillance. My experience as a doula has also revealed the carceral tenets of isolation and the lack of autonomy in the determinant of the birthing room, of the birthing person and their children. When children are born, the hospital system has historically complicated our ability to make food choices for our children in the first days of their life. Decentivizing breastfeeding Black infants is what legal scholar Andrea Freeman calls the first food injustice. Complicated by histories of wet nursing and the forced sale of children, breastfeeding rates for Black women are some of the lowest in the United States. We are currently the lowest, and then Indigenous women are the second least likely to breastfeed. So throughout the 20th century, Black women have been forced to leave children at home to provide domestic labor for other families. And in these instances, breastfeeding can be a painful reminder that our children are not ours, leading to the choice to detach early on for fear of future separation. I've had my own family members tell me that I should stop breastfeeding as soon as possible because you never know when that child could be taken away. As a result of this common sentiment, formula feeding is widely popularized in the Black community. This should be no surprise, since in a 2023 study published in the BMC Public Health journal, there was a study that found that there are the clear policy frameworks that target Black and Latino low-income moms within hospital settings are thriving. In the 1960s, salespeople from Nestle, I should say, which owns Infamil, were sent into the nursery rooms and into hospital rooms wearing white coats, so to appear as health experts when discussing their formula brand to new parents. The $55 billion industry relies on the incentives of doctors, heavy marketing and lobbying to continue to grow its yearly revenue. The rhetoric of breastfeeding as a type of incarceration is echoed by marketing strategies which tap into the inner dialogue of mothers struggling with the lack of autonomy that comes from being in a world that is not very accommodating to pregnant people or new mothers. Many believe that they owe it to themselves to save their sanity, as one op-ed wrote in for today.com in 2018. And the first food injustice is largely predicated on the idea that formula companies, and I quote, are not selling food, but instead selling parents sleep and a peace of mind. This was actually a quote from a conference, and a formula executive said this. So the lack of bodily autonomy is not necessarily made by the fact that people have children, but rather the lack of time off, resources, and support that pregnant people need when they decide to breastfeed. This idea of, the number one problem with breastfeeding is that there's a lack of bodily autonomy is reflected in the public sphere as well. In fact, as Nigel Rollins wrote in 2023 in a study, it's actually the successful lobbying of formula companies that keeps our Congress from enacting a comprehensive parental leave plan on both the federal and state levels. Because if people were given the chance to breastfeed instead of returning to work, many of those who are able to breastfeed likely would never stop. The Carceral Hospital is complicit in bad faith efforts to improve the health of babies. These efforts are so problematic that they're actually banned in most countries. The US is one of 50 countries out of 194 that belong to the World Health Assembly who refuse to follow what is called the Code. And the Code is a set of bylaws that fully acknowledge that formula pales in comparison in composition and outcomes for babies, and therefore follows mandates not to advertise within hospitals, among many other mandates. And to be clear about the level of seriousness of the Code and other international concerns about formula, the Code was originally modeled after the global effort to regulate the tobacco industry in 2005. And so you can actually see the large dips of how successful the implementation of the Code was in terms of regulating the tobacco industry by looking at polling numbers of how many millennials still smoke tobacco. It's an extremely low number. In recent years, breastfeeding is encouraged through more lactation consultations with new parents, breastfeeding classes, and the designation of baby-friendly hospitals, which demands full compliance with the Code. The isolation that many people feel, though, in those first days, if they are in a hospital without an advocate, a support person, or a doula, makes some of these mandates actually very difficult to abide by because they take a lot of resources, right, from hospitals to make sure that people are being offered breastfeeding support, things like that. And so it's actually been doulas that have really filled in these gaps of support for the hospital. Doulas, or trained birth and postpartum attendants, don't just fill in the gaps for breastfeeding, but also other forms of knowledge around birth, caregiving, and infant care. A restriction from their support is one of the key violations of bodily autonomy of Black mothers and infants. Where there's an increasing attention given to breastfeeding in the past 20 years in hospitals, prisons, and jails, there's actually been this parallel that's happened between hospitals, prisons, and jails, and they follow lockstep with passing legislation that honors the human right to breastfeed if people choose. So for instance, we can look at the state of Maryland, right, in 2013, which made effective the Penal Code 9-601, which mandates protocol for incarcerated pregnant individuals. The jail system brought doulas in to effectuate these codes and immediately gave them both the financial and the service burden of compliance, especially around breastfeeding. At current, the Baltimore Doula Project serves at the state's only women's jail, which is in Jessup, Maryland, about 20 minutes outside of Baltimore. And it was actually this organization that raised money for the freezers to be installed for people to freeze their milk. It was not the jail that supplied them. They said, if you want freezers, you're going to have to raise the money yourself. And it's also these doulas that advocate for those who wish to pump milk for their babies. The doulas at this jail are also the only people who are locating kinship care for a lot of the incarcerated individuals. So that means that when they have their babies, they're helping locate family members or sometimes neighbors who can take their babies until the pregnant parent is then released. They're also throwing baby showers for the incarcerated people. They're collecting baby items for the families. And then, of course, they're educating about breastfeeding and just caregiving in general.
Hey, Molly.
Yeah.
I'm sorry to interrupt. These slides are still say Black breastfeeding in the United States, and there's a question about whether they should be advancing beyond that.
Oh, no, hang tight, my friends. But thank you, Wes. So where was I? Okay, so it is worth noting that the doulas, right, were not allowed again in the jail until this penal code was enacted, showing that if they did not need to be there, that there was a very good chance that there would be no birthing support. and there would be no breastfeeding support. So the denial of advocacy and the resources to make healthy food choices within the prison space are really just a few of the ways that hospitals mirror the violence thought to be imposed within prison walls. In both spaces, self-advocacy can feel like an impossibility, okay? And so many mothers that I work with, here's your next slide. Many mothers that I work with have been able to withstand the obstetric violence and trauma surrounding their pregnancies through the very rationalization that they emerged from the hospital alive. One mother that I supported last year for her 5th cesarean section, she still expresses concerns like today in 2025 over her last surgical birth. This is because she has remarked to me many times that the resident performing her cesarean section was talking about being drunk the night before while she was being sutured. And she believes that this led him to being less gentle and cautious and having the bruising that she's, in the complications from her scarring that she still has. But she repeatedly ends this story by being thankful that both she and her child, quote, made it out alive. This is a common part of working as a doula, helping process birth trauma for parents. And almost every, I guess you could say more negative or medicalized story ends with this type of regret and this sigh that's like, oh, well, at least I have a healthy baby. I've heard it even with low-risk mothers who choose to have home births or at birth centers, but then when they're transferred to the hospitals, they deploy this language of being indebted to the doctors that saved them, right? Rhetorically, in English, we even give doctors credit for delivering our children for us, right? It's never us that has had the baby. It is our doctor delivered this baby. And of course, there are many emergencies in birth, but as the philosophy of midwifery argues, birth is not an inherently medical event, nor is it one of emergency. It is a routine physiological event. When considering the abysmal statistic of being 3 to 4 times more likely to die during childbirth than white women, Black women in the US, right, have accepted that the hospital is the complication for us. And in many cases, the hospital is the emergency. So together, these two schemas, right, the carceral logic and the logic of debt run parallel in Denise da Silva's formulation of unpayable debt, where Black women are appointed a debt that is not theirs to economically pay. So on the graphic below, you can see how carceral practices accompany in lockstep the appointment of debt for Black women that results in us being indebted in a very literal and of course figurative ways as well. And I should point out that I use the word appointment rather than accrual, right? Accrual is a typical verb that's associated with debt as one accrues or gathers it over time. But I choose appointed to relay further that debt is not Black mothers to pay. It's actually arbitrarily assigned. So stick with me here. Because Black women and their children have long been the objects of collateral through which reproductive medicine advanced for everyone, mostly white women, but everyone. We're talking about the forced experimentation from the godfather, the grandfather of obstetrics and gynecology, J. Marion Sims, to the centuries of forced reproductive labor, of wet nursing, of our children being sold away from us, to someone like Henrietta Lacks, right, whose cells are in every single vaccine that exists today. Our value and the value of our bodies has been extracted over time, over and over. And so that means that the debt then becomes an unpayable one, even as we are appointed more and more of it through medical care, because the world and the healthcare system as an ecosystem has already benefited so many times from us, okay? So where the debt is not ours to economically pay, Black women have more medical debt than any other demographic, and this is just a deep irony, right? Women who, for instance, women who give birth incur almost $19,000 in additional health costs and pay about $3,000 more out of pocket than women of the same age who don't give birth. And a 2023 KMS study found that medical debt affects people across the US, and it's a significant financial burden on people, especially those with children, because it can exhaust savings, force families to delay or forego basic necessities, and divert resources from other important family needs such as housing, education, and retirement. And last, KFFF polling has found that people in families with medical debt are also much more likely to delay or forego medical and dental care than people without medical debt. So it becomes this very vicious cycle where I have so much debt that I don't want to go to the doctor, right? But then I end up going to the doctor because I can't, let's say, take my chronic pain anymore. And then I go and I find out something terrible and then I'm hospitalized, right? And so like the fees build as you kind of continue to go through this merry-go-round. For those, but there are more physically punitive spaces, right, than that occurs here in the US. And we can see how unpayable debt in the carceral hospital then become collapsed in these spaces. There's a clear connection that can be drawn between American and Haitian women in particular, and all women of the diaspora, and again, what De Silva calls a racial dialectic, which constantly belies the limitations posed by time, both linear and circular. This time function means that the women across the diaspora who are in conversation, we're actually in conversation with one another, and we can both testify to the stark afterlives of capital enslavement and the ongoing disciplining of Black reproduction. Privately owned mission-based hospitals across the diaspora, but again, particularly in Haiti, in places like Nigeria, there's a few in Kenya, they continue to imprison Black women and their children for years after they are born because of these unpaid medical bills accrued during labor and birth. So the highest cost tends to affect people who have cesarean sections or other emergency needs. And this is exposed in a study called When Hospitals Become Prison from Alyssa Jordan and her team at University of Pennsylvania. They did an ethnographic project actually on one of the hospitals in Haiti that is a Catholic hospital and receives funding from the Archdiocese in Philadelphia. And they argue that hospital debt is meant to deliberately target and cripple families who are already struggling to pay bills, right? So the scene kind of that they paint is that there are many women who are in spaces that are not close to healthcare centers. And so when they call an ambulance or they need special care, they're not being brought to publicly funded hospitals. They're not being brought to birth centers that are there. They're not calling the local midwife. Instead, they're driving them specifically to these mission-based hospitals that are then helping them basically get a cut for bringing a high-paying customer to the hospital. But this team writes that in Haiti, obstetrically capable NGO and mission-based hospitals institute user fees, and they're sites where insolvent birthing mothers are sent to undergo C-sections and where they are subsequently imprisoned as corporal collateral for the debt. In spite of rhetoric which situates the patient as the debtor, the practice is in all actuality is used to extract funds from families and communities, and not necessarily just from patients themselves, who are of course imprisoned and thus unable to work or otherwise collect funds. This is why their condition is more akin to that of a hostage held to extract funds from outsiders, rather than that of a prisoner who is held to pay their debt through serving time. Their work clearly relays how the intricacies of class unfurl the definition of anti-Blackness as not just a special type of hatred that non-Black people enact against Black folks, but rather a very specialized form of power that requires all people, even those Black themselves, to shore up white supremacist power in their own demand of paid debt. In the case of these Haitian hospital prison guards that they speak to in this study, they find that the guards are actually forced to mistreat and intimidate those who are imprisoned, and they don't get paid unless they themselves collect the debt. They often learn information about the debtors' families because actually the families must bring in food, water, and clothing for their loved ones. And in this sense, the system of the hospital prison inflicts terror on entire communities, it disrupts families, and it also demands class tradership from those who live in the very same neighborhood. This concept, though, of jailing pregnant people and enslaving their children is not foreign to the United States. So I don't want us to think that it's just something that happens like over there, right? Actually, in an 1848 law from Louisiana, There's one that states that the disposal of such slaves as are or may be born in the penitentiary, the issue of the convicts, and mandated that children must be sold by the age of 10. So when they had people who came in who were pregnant or got pregnant while they were incarcerated, right, these children had to be sold by the age of 10. The money that went into the money that was gathered from selling these children then actually went into a fund that went on to fund Louisiana state schools, and at the time only served white children. The modern mission-based hospital, which then collects money in exchange for mother and children's freedom, goes also similarly into these missions, right? That's actually predicated on things like archdioceses that go on to fund schools in the United States. To theologian and bioethicist Wyland D. Wilson, they argue in Womanist Bioethics that a more encompassing view of Christianity in bioethics, in which God does not condone oppression and it is imperative to defend the vulnerable, really are up in the air when we apply it to these mission-based hospitals, right? And we can really kind of see through a woman, what she calls like a womanist view of a Black womanist view of bioethics, that these mission hospitals are actually antithetical to the idea of Christianity or Catholicism. Okay, so I want to end with a possible new beginning, which is abolition. Just as I stated at the beginning that, of course, a hospital is not a prison, right? I want to be very clear about what I mean by abolition. I understand that the abolition of a major edifice that has become synonymous with healthcare and saving lives sounds like an impossibility, right? I'm already going to concede that. And so I approach the abolition of the hospital as Dorothy Roberts approaches the abolition of the child welfare system, or as Sophie Lewis approaches what she calls the abolition of the family as we see it. And that means that looking at hospital abolition and all of these formations that kind of surround it as really a call to first grow the conception of a community of care. One common retort that people often have for abolitionists who say want to defund and abolish prisons or jails, people often say, well, what are we going to do about crime, right? What are we going to do about criminals? And as Ruth Wilson Gilmore offers, right, as the definition of crime changes over time, our approach to crime policy must as well. That's really where the sticking point is. As hospitals did not begin, right? They did not begin in 2025. They began serving Black people really just in the 19th century, in the late 19th century. That means that we also have to really ask the question, well, what about health, right? So it seems that we're always eager to concede that the definition of health is especially specific for different individuals, people from different cultures and different communities, right? And so we must then also ask how health policy must be radically approached to reflect the individual needs of people, right? The people in Baltimore don't need the same things as the people in Altadena, California, right? They're just different. And so if we parse policy alongside histories that are not actually far away, we could probably come to conclusions that the hospital as an edifice is actually doing a disservice to Black mothers. Policy solutions for Black maternal health is much bigger than calls for more Black obstetricians or more Black doctors, because this really sounds eerily similar to calls for things like more Black cops, as if more Black police could ever end the over-policing of Black communities. But I do want to end here, right, by saying that there is healthcare, even if I don't know what is next outside of the hospital, right, and you might not either, and you remain completely unconvinced by anything that I have said. There is healthcare for Black mothers without surveillance. There is healthcare for Black mothers without bad faith marketing, and there is healthcare without debt. But we have to first renegotiate what it could mean, right? A hospital healthcare could really mean without relying on the devaluation of Black mothers and entire communities. So I'm going to end it there.
Wow. That was amazing, Molly. Since you started off with that and it was such a prominent part of your talk. I want to give you statistics from a paper that two of my teachers wrote, Steffi Wohlhandler and David Himmelstein, who founded Physicians for National Health Program, along with Elizabeth Warren, back when she was, quote unquote, just a Harvard law professor who specialized in bankruptcy. But they wrote a paper, and I think it was published in 2009. They repeated the study about a decade later that showed that of people who filed for bankruptcy in the United States, over 60% of them cited medical reasons as one of the reasons for bankruptcy. So not the sole reason necessarily, but one of the reasons. And they found that 3/4 of the folks who filed for bankruptcy, citing medical reasons as one among others for why they filed, had insurance. So over 60% of bankruptcies are medical in nature to some extent or other, and over 3/4 of those folks had health insurance. And they found that the majority of folks were well-educated, owned homes, and had middle-class jobs. I wonder what your thoughts are on that finding in relation to all of the data you presented this evening.
Yeah, so I think that that rings true for the statistics that are specifically about mothers and about people who have children. The KMS study that I cited from 2023 actually found that people who were still incurring out-of-pocket costs also had two insurances, or sometimes we're still using state-funded insurance, right? So Medicaid. And then had about people who are on Medicaid had an average of $3,000 of out-of-pocket expenses. So it really turns on this head, this idea that, oh, well, people, especially Black mothers, welfare queens who are living off of the state are really just getting healthcare for free, as if there's something wrong with that, but they're getting healthcare and services for free when really it's actually not free at all. And to your point, right, it's not free for even people who are low income. It's not free for people who are upper income, cross-racial demographics and things like that.
Exactly. And so to what extent is this a unique, and you sort of said it, but I'm just going to ask the question, a uniquely American phenomenon, given that we're the ones with the history of slavery, of mass incarceration, systematic bias, and so on. Like, is this uniquely American? And if not, to what extent?
So I would say that the phenomenon of fiduciary medical debt is 100, it's apple pie American, is baseball American, is 100% American. But of course, the idea of debtor prisons, it's actually, it's in the Philippines, it's in Burma, it's in Nigeria, it's in Kenya, it's in Haiti. And journalists mainly have done this work of uncovering these different debtors prisons, but they do find over and over again that it's just a particular mother thing. It's a mother and child issue. But no, to your point, that the phenomenon of medical debt is absolutely American. And of course there is debt other places, but people are given opportunities to either garnish like their checks for it, or they are given opportunities to settle. It doesn't cripple them from buying homes. It doesn't cripple them from going back to the doctor, as it does in the United States. And so, it's just one of those many things that I'm sure was cited in the Elizabeth Warren study that, preclude us from chasing the quote unquote American dream.
Thank you. One of the questions that we got actually before your talk is the following. What are the top 3 actionables clinical ethicists could implement in our in-hospital roles to improve both the experience and the outcomes for Black mothers and infants?
So one is the number one that it seems like an impossibility because of rounds and just labor in general, but it's spending time with people. Often people do not feel like they can trust their providers, and that only increases with seeing people more, right? The obstetrician is in the room maybe once an hour or less than that, usually for a birthing person. So I would say spending time. Understanding these problematizing this term, but the social determinants that go into that shape your patient's life, I think is really key. And last, I would say understanding your patient as a whole person. So again, I know just that seems like a double on the social determinants, but I think it's really important that your patient can feel comfortable talking about all aspects of their life. We know statistically that mothers and Black mothers are, for instance, using cannabis during pregnancy. And if they were able to talk about that more freely, I know there's lots of complications with that, we could actually treat them better, right? And so, yeah, I would say time/presence. I don't remember. I can't list them, Wes. I totally forgot now.
That's okay. Someone wrote in the chat, could you say more about your vision for hospital abolitionism, how it counters and unsettles carceral logics enacted through the hospitals and healthcare broadly conceived?
Sure. So I would say that from my research that I have concluded that hospitals should really be places for extreme medicalized cases. We should have multiple steps before someone goes to a hospital. So that means that there should be people within communities that you can call to make house calls to your home that are low cost or low paying, as we have pretty much in every other country but the US. There should also be clinics where people can access that you can access through public transit, again, that are low cost or free. And then we should also really talk about what it looks like to have, when I say community of care, there are multiple health models in which people aren't individually in a room by themselves. I know in America, we love to be by ourselves and we love our privacy, but when you actually have rooms where there are multiple people, then you form a community with the people in your room, and everyone is able to kind of talk about what's going on with your case. Maybe they could suggest things. Usually people know each other, right? And so they can add like flavor and contour to someone's case. And so I just think that there should be multiple really edifices and just structures put in place before one has to go to the hospital, so that we can also reserve the hospital for extreme cases and people that need really serious medical care.
Excellent answer. A question that came in before your presentation, what specific training or curriculum changes should be implemented in medical, nursing, and allied health programs to see and address disparities in Black maternal health and improve outcomes for Black women?
So again, with the reproductive justice approach, then we can really see how Black maternal health is not just about someone carrying a baby, but it's actually about the right to clean water. It's the right to not living in an environment that has floods, an environment that has lots of gun violence and things like that. And so I would actually say that, of course, you know, I think there needs to be reproductive justice classes, but we need to actually expand what that means. I also think that as someone who's someone in medical humanities, there is so much evidence in the histories, and this is really the task of my first book. There's evidence within histories that are creatively written, right? So if we look at historically, Black women have not been able to authoritatively teach or authoritatively write, right, in a more medical sense. We've written those testimonies down in novels. We've written those testimonies down in poems. So I think that there actually needs to be a mandate of humanities training, and so that we can develop critical thinking skills, right? I always say the reason why we are in a mess with COVID, the reason why we're in a mess with Black maternal health is because we lack critical thinking. We need to have courses where people can actually learn the skills of critical thinking. And unfortunately, that doesn't start or end with reading case study on case study. It's actually about reading about history, affect, people's feelings and their experiences. And it also sometimes involves art, which, you know, is an inconvenient truth for a lot of people.
So true. So what about in today's climate where we live, where facts don't really seem to matter to a lot of people? I mean, how do you respond? I mean, I'm not even sure how I respond, but what about you?
You know, yeah, facts are shifting, right? We have alternative facts. I would say, of course, critical thinking helps us understand what is a truth and what is a lie, but also you cannot replace first-person experience. And we do live in a country that is largely segregated, not just within our cities, but in our counties, right, in our states and things like that. Nothing takes away from first-person experience with someone who's not like you. And so I think at the very least, right, we need to be broadening, again, our community or just our we need to go outside larger than what our nuclear family is in times like this, because we don't have comprehensive media training. We don't have comprehensive fact training, honestly, on a daily basis for the average person.
Yeah, and I can't agree with you more that just being with people who are not like you, however you're defining like, just goes such an amazingly long way toward realizing that, you know, we're all in this together and there's a lot more, perhaps, commonality than difference. It also makes it a heck of a lot harder to make generalizations about the other, however you're defining the other. I'm going to try to read from the chat. I'm sorry, the Q&A. It's really blown up. Excellent presentation. This topic hits home. Being a Black woman from Louisiana myself, renegotiating hospital systems to improve health outcomes and eliminating medical debt requires leadership and state recognition of the issue. How can we effectively challenge policymakers who dismiss the Black maternal health crisis and advocate for ethical policy changes?
Well, that comes in a really difficult time where, you know, it's like, I don't know what's happening with policy, right? I think I just saw that we're trying to rename Greenland to something like the red, white, and blue land. But, you know, I mean, that's like a real thing. I think it's really important now for people, especially millennials, to stop being afraid of the telephone and to call legislators. I say this from a place of geographic privilege because I am close to DC, right, where you can actually go and talk to your representative, but people need to absolutely be doing that. I would also say that it is extremely hard for Black women activists to not appear because of stereotyping as like angry people who are blowing issues out of proportion. I think that means that people, especially people with MD after their names, absolutely need to be heralding this charge because they see firsthand what is happening in some of these hospitals. I know there are liability issues, and I know everyone's afraid of those things, but I think absolutely healthcare professionals and doctors need to be at the forefront of those policy changes as well.
Yeah, the two teachers of mine I previously mentioned, Steffi Wohlhandler and David Himmelstein, are both doctors. They're both activists and, you know, promoting single payer healthcare. And they have said for a long time that, you know, if you have MD after your name, it may not be right, but you may have a little bit more of a voice that would be heard in certain public forums. What you just said brings me to one of the questions that was sent in before your talk. As OBGYNs increasingly identify the importance of advocating for reproductive justice, we are seeing more institutional policing of the quote unquote correct and professional forms of advocacy. I worry this may stifle more critical forms of change making related to reproductive justice, especially that challenges fundamental norms of our healthcare system and institutions that remain quite colonial. What thoughts, background, and/or advice do you have for this? That's an easy question for you, I'm sure. If you want me to repeat it, I can.
No, I mean, really, it made me think, a personal experience of when I was living in Los Angeles as a doula and, you know, serving people in hospitals. And then one day, I go into Cedars-Sinai, I should just shout it out, hey, Cedars, that they wanted me to sign a Bill of Rights, a doula Bill of Rights, before I could support my pregnant person. And that was it was like 10, a list of things I could not do. And then I would sign that, saying that I would not do these things. I would not, you know, speak on behalf of my client. I would not perform medical tasks. Some of these things are, of course, like things I wouldn't do anyway. But really, if you look at them, and now I've had to sign these at every single hospital I've been in since, and I think that was in 2019. You have to sign, doulas and advocates have to sign forms saying that basically we won't advocate or we won't speak directly to doctors or healthcare providers, which completely, I mean, it's like there's no point of having a doula almost during like when those are the conditions. But I will say this though, that there has to be, until again, doctors stand up to some of these pernicious practices and kind of actually accept and acknowledge that we are providing the the support in the healthcare that the RNs don't have the capacity to do in some cases. Doulas are still going to just keep going into hospitals as sisters and mothers and friends because I think that this type of like surreptitious activism that's growing can be a dangerous one, but at the same time, it's been needed, and that's how we're getting around these type of like these institutional blockages.
Yeah, very well stated. Here's a great question for our current times. Thank you so much for this. Well, it's a statement and then a question. Thank you so much for this amazing presentation. How do you feel your research and work will be impacted by recent political efforts to limit or even ban words like gender, women, pregnant person, pregnancy, etc., in research grants and academic publications?
Oh, that's a really great question.
That's why I read it.
Thank you, Wes. So I'll say this: on a personal level, I worry about getting jobs. I worry about getting grants, things like that. I will say that it's really my type of fear, though, pales in comparison to like the lived bans that people are living with. At my home university of American University, just one day we just went and they took all of the non-binary bathrooms away. Right. So there are actually like lived consequences to what we're doing. And I guess I could be a hero and say like, my career doesn't matter. And, don't look at me, look at the people who are really struggling on the day to day. But no, I think it's your question actually speaks to the fact that we're all under siege. Everyone is under siege, just to varying degrees and on different registers right now. And so that's actually why the work is actually more important. The work is ever important now. And so even if it's not going to be published in journals, spoiler alert, no one reads journals anyway. It has to be published somewhere else. We have to be advocating in our communities and teaching other places.
Yeah, and even though I'm an academic, I'll tell you what I've heard from my teachers years ago was that the average paper published in an academic journal gets read by exactly 3 people: the author themselves, the editor of the journal, and the reviewer. And I have forever been a complete and total believer and advocate for what you said. If you want to get a message out, you can publish in the academic journals, but if you want to amplify the message, figure out how to get it into the lay audience, with some rare exceptions, very high profile journals. I'm going to ask a couple of more questions from the Q&A, which are related. Can you say more about how midwives and doulas can assist in countering the financial aspect of medical care? And there was another one that's related. How can you perhaps get OB/GYNs and hospitals to be less resistant to having doulas involved in the birthing process?
Sure. So the first question, as someone who's had a home birth, and then also someone who was trained in exchange, I would say that doulas and midwives are still operating out there on bartering systems, right? And so, unlike a hospital or something like that, right? I had like 3 years to pay off my home birth, 3 years to make my home birth bill, right, which was around like $5,000. Also, again, there is bartering going on, and unfortunately, those types of things aren't legible in like a hospital space. But again, that builds our community of care. I know doulas who have done births for year-long gym memberships and things like that. But I would say in terms of getting hospitals to accept doulas, I don't really know, because the growing consensus is that doula care advocacy is perpendicular to proper health outcomes. And that's just erroneous. And so all we can, I'm led to believe then that it's about not wanting someone there to witness violence that's occurring, right? There's no other reason why you wouldn't want another person helping someone in a room. I would say that, again, humanities classes are important because we need to, I think that at somewhere along the line, a lot of healthcare providers have just decided that patients are just like these robots that don't have thoughts and feelings. And again, the humanities training helps us understand and see other humans as humans and not just test subjects or some sort of inanimate object.
Well, we're at the top of the hour. That's not a bad place to end. I can't thank you enough for presenting tonight and then having this dialogue after your presentation. It's cutting edge, it's thought-provoking, it's vitally important. We have a long history in this country, and you've certainly shed light on a portion of it. So thank you for tonight, and I'm very excited to be having you as a visiting scholar here in the Center for Bioethics at Harvard Medical School in the fall. Thank you again, Professor Collins.
Thank you, Wes. Thank you, everyone. Have a great night.